I'm Adrian Boyle. I'm Vice President of Policy for the Royal College of Emergency Medicine, and I'm here with a long-time associate and friend, Dr Prentice, who is chair of our lay committee and has been a staunch supporter of the college for how many years now, Derek?
About 7.
7, okay. And we think it'd be useful to tell members and fellows about the RCEM stance on NHS 111 talk before you walk programs. So the college has produced some FAQs about the changes to the 111 system. And we're going to just go through what we think are the important things about the NHS 111 system. So Derek, do you want to start grilling me on this? You've been a critical friend to us, which has been extremely useful.
Thanks for that, Adrian. Adrian, is this the introduction of this new process, is this for COVID or is this for the longer time?
So I would say that this is almost certainly not going to help us very much with COVID. One of the things we saw with lockdown is that a lot of the lower acuity patients stopped going. We saw dramatic drops in the number of people turning up to departments in April, May and June. And those patients, most of which, but not all, were low acuity patients. So this probably won't, this is a long-term solution, and it's probably going to have its greatest impact when we get out of the next wave. I don't want to say wave because, you know, COVID never went away when we're having a sustained surge in cases, which is what's beginning to happen now.
Adrian, you know that we totally appreciate, and I'm sure most patients appreciate, the great pressure that you and your colleagues are under and have been under for some considerable time. But there are very real fears out there amongst patients that NHS 111 isn't always the greatest of services and that you have to wait a long time to get called upon, and often the advice is confusing to say the least. But above all, that alternative services that are being offered under this new services in many areas simply don't appear to exist, particularly on a 24/7 basis. Isn't this going to be a real threat to patients?
I would hope not. So, you know, emergency departments are still open. No one's suggesting that emergency departments are closed. And if people are seriously worried about their health condition, they'll either call 999 and get an ambulance or go to their emergency department. Where this is different is actually if you turn up to the emergency department and somebody at the front door thinks, and you, a clinician thinks your care need could be met better elsewhere, you might be encouraged to phone NHS 111 beforehand. And that's really just making official and providing a better mechanism from what triage nurses have done for years. So lots of hospitals, triage nurses will have looked at something with that slightly skeptical eye and gone, really, do you think you could have gone to this place? And what all this is doing is actually making that a little bit more formal, providing some sort of audit trail and a bit of governance around it.
There's been some fear expressed, particularly from evidence coming back from some of the pilot sites, that in fact patients are being just sent away, being told, or given an iPad and told to almost get on with it and contact 111 through the iPad. This has caused a number of concerns. Are we actually saying that if patients turn up, they simply won't be seen if they haven't got a serious enough issue to be addressed by the ED department?
No, so we accept that patients, and it's very difficult for patients to know how serious their complaint is. But what this might do is increase redirection to other services. Now, I absolutely get that NHS 111 is only as good as the directory of services behind it. And we know that there are problems, particularly around weekend cover and out of hours cover. So I can assure you, if people will still be able to turn up at an emergency department, but they'll see a clinician who might say, you need to phone NHS 111.
Okay. GPs apparently can't make appointments for you, but they can direct you to an ED department. Is that the situation?
So this is a question about, and Derek's asked me about, do GPs have the ability to make appointments within emergency departments? And that's really never been the case. And the complexities of trying to organise that would be extremely difficult. So I work in a city which has 30 GP practices, most of it using different IT systems. And the idea that they could book somebody into an emergency department, I think would be really, really difficult. NHS 111 in certain places are providing various appointments. Now, it seems a strange thing to do to offer GP appointments in emergency departments, but the advantage of that is it allows us to put appointments when waiting rooms aren't full.
Okay.
And it helps us with the social distancing in the waiting room.
Yeah. Some people say that whenever they call NHS 111, they always send them to their local ED. When you get there, they're being told, you need to ring 111, and it gets into the kind of a circular problem. What do we do about those kind of cases?
So first of all, I'd actually say the data doesn't support that. So there is about 10% of people who phone NHS 111 get sent to emergency departments. That's 90% that don't get sent there. They send far, and they advise many more people to go and see their GP, and they also advise other sorts of advice, self-care or pharmacy advice. So there is widespread variation across the country, and the college has got data on this where there is a real range between 8 and 15% of people advised to attend their emergency department. And we think that variation is a problem and should be addressed. But actually, it's not true that NHS 111 always sends people to A&E.
Okay. When the patients ring 111, are they going to be speaking to clinically trained respondents on the phone?
So NHS 111, when you phone NHS 111, you are put through to a call handler. That person will not necessarily have a clinical training. They will have some form of training, and that will vary. But they will not necessarily have they will not necessarily be speaking initially to a clinician. There is a process by which they can speak to a clinician afterwards, and that happens in about half the cases. It's got better over the last couple of years. It used to be that it was incredibly variable. We now think about half the calls that go through to NHS 111 have some form of what is called clinical validation. Either that's a phone back or a discussion with a clinical professional. We're very keen that more people are offered a chance to talk to a clinician. We think that's important.
Are you confident, Adrian, that you and your colleagues have sufficient information and data about alternative services to be able to redirect people when they turn up and perhaps need to be seen? It will be advantage for them to be seen elsewhere.
So the question here is about whether staff working in emergency departments have sufficient information about local services. And I can absolutely assure you that most staff working in emergency departments don't have enough information about local services. But actually, this is one of the things where NHS 111 is better than your emergency department, because they have an up-to-date directory of services, and they do put a lot of effort into that. So frequently people will phone NHS 111 and be directed to a service that actually the emergency department staff may not be aware of.
Okay. If I ring 111, they make an appointment for me to go and see my local hospital, and I don't turn up, is there any mechanism for checking that I'm okay?
So there's a good question about whether if someone goes to NHS 111 and they're advised to attend their emergency department and they don't turn up, there needs to be some sort of mechanism about how that happens. Now, NHS 111 send information to GPs, and in some of the pilot sites, they're sending information to the emergency department. I still think that's an area of risk, and I still think we need to do some work to try and understand that better.
Talking about risk, how do we try to, or how does the college try to ensure that people with really serious conditions actually are encouraged to not to hang about, but to call 999 or just go to their local ED?
So I think this is difficult, because I think every emergency physician will be able to tell you of people that they've seen where initially they sounded with a presentation that sounded fairly innocuous, that turned out to be serious. And I think it's difficult, and I think there are things which are very obvious. If people are bleeding, if people have gone weak down one side, if they're having a fit, or they've got severe chest pain, or they're breathless, that's fairly straightforward. They obviously need urgent help. I think it becomes harder with things like abdominal pain, headaches, where the majority of cases we see aren't serious, but within that haystack of not serious cases, there are needles.
Yeah. I want to return to an earlier question, and that is the lack of availability 24/7 of many other services. And I know this is something of concern to you and your colleagues. How do we actually deal with, and what advice are we going to give to patients that really are concerned in the middle of the night, but are being advised to be redirected or to wait elsewhere. Who's going to actually provide that all in? I remember one of your colleagues actually saying that reassurance is a great service to be able to provide to patients that are worried. And in the middle of the night, I'm sure you're more experienced than I am, that patients are worried about issues, and being told you need to wait for an appointment the next day to see your GP or whatever isn't really always going to help them.
So, I mean, I think this is that's an excellent question about what to do out of hours when people's health anxiety is high. I think we have to be sensible, and people will be able to find cases where a triage system like this makes mistakes. Triage is never perfect. And I think we need to give people we need to empower them to make the right decision for themselves. We also know, particularly from Sue Mason's work up in Sheffield, there are lots of people who come to emergency departments in the evening and when they finished work, because it's personally much more convenient. And some of this will be around being unable to get time off, unable to get people to look after their children. And GP services need to be providing that sort of care. Now, that's a really difficult question, but actually one of the things the college is pushing very hard for is alternative access. We have a CARES campaign, and the second letter of this is alternative access, because we can't, as our emergency departments must not become the system failure service.
If I turn up without an appointment with something, am I ever going to just be turned away?
Well, I think that would be I think you'd need some form of clinical assessment before you were sent away. I think it would be unsafe and the college has always said that you need to be seen by some form of clinician. Now, remember, triage nurses who are usually experienced nurses who have a lot of experience of people turning up to emergency departments, have been sending people away for years. They may have couched it in such a way as well, a slightly raised skeptical eyebrow. But if you spend a bit of time sitting next to a triage nurse, you'll actually see that they will do quite a lot of redirection. I think we can do better than putting that responsibility just onto the triage nurses.
On that particular point, this is to really work well. This is going to require an awful lot of colleagues in other specialties within hospitals, isn't it, to step up to the mark and provide the kind of support and provide the kind of clinic access that patients that may be better seen by them than in the ED departments to provide those kind of services. Are we talking to those people to try to encourage them to take on this additional work?
Yeah, so that's an excellent question. So how are we going to get other specialties involved with this? So the NHS England are pushing what's called same-day emergency care very hard. This is and the college is supportive of this. It is recognised that there are lots of patients going into emergency departments who have complicated care needs, who are on very complicated medication regimes, who've got long-term chronic complicated health diseases. And when they go to emergency departments, being looked after by an emergency department doctor, an emergency medicine specialist, is not what they need. They need people who understand all the nuances of the medication they're taking, the nuances and the complications and the factors of their disease. So we're very keen that people who are being looked after by inpatient specialties continue to be looked after and have some way to access support. I'm not very good at looking after people with complications of chemotherapy. I can deal with neutropenic sepsis, but actually, if people have other complications of chemotherapy, they need to see an oncologist, somebody who understands and lives and knows about all the complications they can have.
Adrian, a couple more questions, maybe, but vulnerable groups. Obviously, there are many people in our society that are extremely vulnerable, the homeless, people with mental health issues. This is going to be hard for them, isn't it? How are we going to make sure they don't fall through the net?
Well, I think we've got to use a bit of discretion. We're not saying that people can't turn up at emergency departments. What we're saying is, if you turn up at an emergency department and we think you might be treated better elsewhere, we'll help you with that, and we will direct you in a way to do that. If somebody turns up who's in a florid mental health crisis, of course we're going to support them. Likewise, if it's obvious that the person can't use a phone because they're homeless and they've got multiple problems, of course we're going to look after them. That would just be uncivilized not to. But If you look at the first example of the person with mental health crisis, my own department has something called a first response service. So it's a mental health response thing, which is an NHS 111 service. And a patient is given a phone, they speak to a psychiatric nurse over the phone. The service is incredibly popular with patients. They're very keyed into what services are around. They will say, this person actually needs to be in the emergency department, or this person can go to this place. And they organise all sorts of care. They often have access to the patient's records on the psychiatric note system, and they can often provide much more holistic, much more sensible, and much more timely care. And if we can get that right for people with mental health crises, we can probably get it right for less vulnerable groups.
Yeah, sure. A key issue, I think, for you and your colleagues, and indeed for patients in the longer term. How do we ensure that this development isn't in power as we've solved all the issues of emergency medicine? How do we ensure that, in fact, all the other demands we have for better financing, for better, more posts, better capital expenditure, to have better departments, isn't now pushed aside because those in power think they've solved the issue by this new service?
Okay, that's a perfect question. So there is, this is not the solution to all the problems in emergency departments. In fact, it is a tiny solution for a much, much bigger problem. We're much more worried about exit block, the fact that we're underbedded, understaffed, the demand that we are very much the squeezed middle between inadequate community provision of services on one hand, and on the other side, inadequate bed capacity within hospitals. This is a tiny solution for a much, much bigger problem. And we will be absolutely calling out government if they think that this is the only solution. However, we are accepting this because we are endorsing this because we recognise crowding in our emergency departments is a problem which has multiple causes and therefore requires multiple solutions. It would be overly simplistic and unhelpful just to say we need more beds in our hospitals. Mm-hmm. We've got to actually think there are multiple problems, therefore you need to have multiple solutions. But again, tiny solution for a big, big problem. We're not going to try and eat the elephant in one go.
This is a major change, particularly for patients. What is going to be the major benefit both for us as patients and for the service as a whole from the introduction of this new requirement that we need to call before we walk?
Okay, so the question is about whether what is the benefit for our departments and what is the benefit for our patients. What I am most worried about now, and as a clinical director of my department, what keeps me awake at night, is the idea that our emergency departments become the source of another outbreak of COVID. And I hope some of this will reduce the total occupancy within our waiting rooms. The idea before COVID, our waiting rooms and our corridors were regularly full to bursting, and it would be like, Piccadilly Circus with everybody sitting cheek by jowl. This isn't going to help with the corridors. This isn't going to stop people who need to be admitted into hospital, majors patients, but it might help just a little bit with the people the self-presenters who sit in our waiting room. And I'm really worried that having people sitting next to each other will increase the risk of what we call nosocomial infections. I've seen studies where people talk about 1 in 8 cases of COVID were acquired in a healthcare setting. We mustn't become the reservoirs infection for COVID.